Stress ECG, case study 1. Alright, so this is very similar to what you've done in the block program, but I've decided to make it a video to just recap the importance of what every page means when we have a report in terms of the ECG, the stress ECG that we've done. Alright, so we firstly have a summary page which include things like the final protocol, which indicates blood pressure, heart rate, and workload. We've also got a summary of different variables, which I'll discuss in more detail. And then we've got also a summary of each ECG waves, specifically channel V5 in rest during the first phase, during the last phase, which is has the highest intensity, and during recovery as well. So if we firstly look at this schematic, this figure over here, you can see these vertical lines. These vertical lines represent systolic blood pressure and diastolic blood pressure. The dots at the upper part of the vertical line represents systolic, and the dot at the lower part represents diastolic blood pressure. Okay, this horizontal line or curved line, as you can see, represents heart rate and how it changes throughout each workload. And then this gray blocks represents workload. So therefore we've started with 25 watt, moved on to 50 to 75 and then 100. Didn't finish this stage, however the test was stopped after that, and then it went into recovery. Alright, if we're thinking of blood pressure, typically systolic blood pressure should increase with an increase in workload. Diastolic blood pressure typically remains stable or goes up or a bit down, but not a lot. So this is quite normal blood pressure response to an increase in workload. Obviously, blood pressure will decrease in cool down or recovery. Heart rate has a similar tendency as systolic blood pressure, where it increases during when there's an increase in workload and decreases during recovery. Alright, so the summary page include a lot of values that is of clinical importance. The first one is the total duration of the test, how long the test lasted. The second value here is the duration without the warm up and cool down. So this is only the time that the person was stressed. Then the duration of the warm up and cool down as well. Then the maximal workload, which was 100 watts. Then the heart rate peak. This isn't the person's maximal heart rate. This is the heart rate that is peaked at during the test. So the highest heart rate. Alright, then we get the blood pressure resting, the resting blood pressure value, which was 110 over 82, and then we get blood pressure max, which was 142 over 80. Then we get double product or rate pressure product, the maximal double product, which is indicative of how hard the heart is pumping, or also the myocardial oxygen need. Alright, so this is of clinical importance because we can use it in cardiac rehab. This is the maximal double product. Then we get the MET value. The MET value is, as you would remember, multiples of resting metabolic rate. So what this means, the maximal MET value was 4.5, which means that the person expended 4.5 times the amount of energy as during rest. Alright, then we get a summary page of all the ECG leads, no, not all the ECG leads, specifically V5, because remember V5 is situated directly over the left ventricle. And remember, the left ventricle works the hardest because it needs to pump blood to the rest of the body. That's why the system have chosen lead V5 to represent a summary. Alright, then we get the frequency. The frequency is the horizontal frequency. This is incorrectly set at 50 millimeters per second. It should be 100 millimeters per second. What this means in practice, if you, for example, want to classify a first degree AV block, we know if the PR interval exceeds 0.2 seconds or one big block, it means we can classify this person as having a first degree AV block. But because of this frequency set, it means that you need to take 2 blocks. So if the PR interval exceeds 2 blocks, then we can classify a person with a first degree AV block. The amplitude is correctly set. Remember, this is also important because, for example, when we evaluate left ventricular hypertrophy and we count the S wave of V1's amplitude and sum it with the R wave of V5 and get more than 35, we note that the person has left ventricular hypertrophy. The first line here represents resting ECG, then the first stage, then the third stage, which is the maximal workload, and then the recovery stage as well. Alright, then we get a report. The report is an automatic report which is generated by the system, and therefore it can make mistakes. Alright, however, what this tells us is firstly minimum stress. So what this means is we didn't apply a lot of stress to the patient, and it determined that by means of the low increase in heart rate during the test. Alright, then we get the maximum load, the workload information. So the max load was 100 watts, and that was reached at stage 4 at 15:03. That was 37% of the target, which was 265 watt, which is quite high, and this represents a MET value of 4.5. 4.5 times more energy expended as during rest. Then we get resting heart rate variables like resting heart rate. Resting heart rate of 101 beats per minute represents sinus tachycardy, and the maximum heart rate was 118 beats per minute. Maybe this person was stressed before the test. However, this person's heart rate only increased with like 17 beats per minute, which is very, very low, and that's why it's minimum stress. Alright, the person reached 74% of their target heart rate, which was 159 beats per minute. Then we get ST segment information. So there was remember, if ST segment in elevation or depression exceeds 0.2 millivolt, then it has clinical importance, and it did, especially in lead V2. The highest one was 0.26, and this was found during the recovery stage and can be indicative of injury to the heart. Then the maximal ST segment depression was in AVR, which is inverted, so it's actually ST segment elevation, and that is not of clinical importance because it does not exceed 0.2 millivolts. Then the next one is ventricular premature beats. So the system counted during the test how many PVCs we found, and they said 6. However, as you will see when we're doing the report, it was definitely more than 6. And then last thing, this is what you enter, why you stop the test. Finish test isn't a very accurate thing to write. You can rather write things like target heart rate attained, or person felt fatigued, person wanted to stop, whatever. Alright, then we get different summaries of each wave during each stage. So this first column represents the resting phase, then the warm-up phase, the stress phase, 1, 2, and 3, and 4. This was the maximal stress phase. Then we get the cool-down phases, and that represents a summary of all the leads. So yes, so this is quite a nice thing to see because you can see how the wave changes throughout the whole test. However, to determine rhythm disturbances will not be cannot be done here because we want a strip of ECGs. Like for example, these parts. The system automatically records the last 10 seconds of each stage. So this is the last 10 seconds of the resting phase. This is the last 10 seconds of the warm-up phase. All right, then we get the last 10 seconds of each stress phase, phase 1, phase 2, phase 3, and phase 4. And then we get the last 10 seconds of each cool down phase, phase 1, phase 2, and phase 3. And then what's quite interesting at the last one is here you can see a PVC occurring during the last 10 seconds of the last part of cooldown, the phase 3 of cooldown. Then to determine if there's any rhythm disturbances, the system also gives us each and every wave, ECG wave, during the test. And what is very apparent when looking at this part is it's very easy to see if there's any rhythm disturbances, especially premature ventricular contractions. We get two leads, channel 2 or lead 2 and lead V5, because remember, it's important to have two waves because sometimes one of the leads can get loose and then you might think it's something physiologically that's occurring, but the other lead can be good, and therefore it was a technical error in one of the leads, and therefore you can't interpret that lead at that time, but you can interpret the other lead. Like for example, if V5 gets loose, you can still say look at channel 2 and see if everything is correct. All right, this will help you to identify or differentiate between technical errors and real physiological or real ECG changes. All right, why specifically these two leads? V5 again is right over the left ventricle, the workhorse of the heart. However, channel 2 is also a very nice lead to look at because remember it is exactly in the direction of the heart's conduction. So very good leads to look at. And then literally it gives us each and every ECG waves during the resting phase, during the warm-up phase, and during the stress phases. And as you can see, it's really easy to identify premature ventricular contractions. All right, we can also count it. Each line represents 1 minute. Not 1 minute, 0.00 to 0.014, so 14 seconds. This is really nice to determine rhythm disturbances. Then we also get other tables and graphs and to help us interpret an ECG, like the workload, the heart rate, the revolutions per minute. This is if you've attached and connected the bike ergometer with your system, which we did not. Then you also see blood pressure responses, and then you see ST segment changes in the cardiac leads and the limb leads. Sorry, this 3 over here and this 3 over here represents the limb leads, and this 3 over here and this 3 over here represents the cardiac leads. All right, then we get also a table which gives us values. This is typically also what you do when you do a PwC test. You write the heart rate, the blood pressure, and the workload. But now we get additional information. For example, we get MET values. We also get ST segment changes. And now it's really easy to identify if there's any significant ST segment elevation values, because remember, if we look at elevation of 0.2, more than 0.2 has clinical importance. If there's a minus, it means that is ST segment depression. As you can see, V2 does have ST segment elevation that has a clinical importance. All right, so yes, we can determine if there's injury to the heart here. So let's go through this specific case study. Firstly, we'll do rate first. This is the steps to ECG interpretation. So as we've seen, there was only a slight increase in heart rate. The question here is this patient on heart rate suppressive medication like beta blockers, for example? Because this is why you need to take into the medical history into account when interpreting case studies of ECG or when interpreting a stress ECG. We can see, however, that the systolic blood pressure increased more and was better. Also, this person's heart rate initially was very high, so his resting heart rate was 101 beats per minute, indicating sinus tachycardy. When we look at rhythm, we look at these specifically this all of the waves. This is very nice to identify. What I've done here is I've counted the amount of PVCs per minute. And remember, if there's more than 6 PVCs per minute, the test should be stopped, because this is indicative of pathology occurring, ischemia of the heart. And as you can see, from minute 8 till 9, there was 11 PVCs, and that is this test should have been stopped over here actually. However, there was other minutes that also exceeded 6 PVCs per minute, or equaled 6 PVCs per minute. This was in stage 3, the second minute, stage 3, the third minute, also stage 4, the second minute, and then they've stopped the test. And during the first minute of recovery, there was a lot of PVCs. So what's interesting about all of these graphs is you can also see the configuration of the PVC. And most of them look alike. Like, that means it's the same PVC firing continuously throughout the test, which is indicative of unifocal PVCs. However, there was one PVC that did not look similar to the others, and there you can see it. So therefore you can actually say it's multifocal PVCs. Just to show you how it looks in greater detail, you can see the PVC from, if you during the test, you can mark a specific time when you see the PVC to get a better illustration of the PVC. And as you can see, here's the limb leads and the cardiac leads, and when looking at this, we can say the origin of the foci is more or less over V5, V6. You can see the high amplitude of the PVC's QRS complex in V5, but also in the inferior leads, which is lead 2, lead 3, and lead AVF. These leads, sorry, that's not AVL, that should be AVF. This is inferior lead, so that means there was ischemia in the lateral inferior part of the heart. In terms of axis, remember how to determine frontal axis by means of looking at lead 1 and AVF. Both of them was positive, so there was normal frontal axis. Then to look at horizontal axis, we look at the negative S wave in V1 and the positive R wave in V5 and V6, and the progressive decrease in the ST segment, in the S wave amplitude as we move from V1 to V6, and the progressive increase in the amplitude of the R wave from V1 to V6. We also look at isoelectric waves in V3 and V4, and there was isoelectric waves in V3 and V4, and that means it's normal. Remember, isoelectric waves means that R wave the R wave's amplitude equals the S wave amplitude. To look for hypertrophy, we look at lead V1. Lead V1 is situated right over the right atrium, and therefore a very good lead to observe atrial hypertrophy. We look at diphasic P waves, which means they have two phases. They might have an upper part and a lower part. However, this P wave in V1 looked normal, and therefore there was no left or right atrial hypertrophy. Then in terms of ventricular hypertrophy, we look at lead V1, specifically for right ventricular hypertrophy. If there's a big R wave in V1, we can say, we can indicate a possibility of right ventricular hypertrophy. Remember, to identify left ventricular hypertrophy, we look at the S wave of V1 and the R wave of V5. We sum those values, and if that exceeds 35 millimeters, it means there's left ventricular hypertrophy. Both of these situations that wasn't observed in the ECG, so no left or right ventricular hypertrophy. Then we get to the last step, which is infarction. There was no inverted T waves. Remember, we can't identify inverted T waves in lead AVR because that whole lead is inverted. Remember, ischemia is also not firstly identified by inverted T waves, but by means of PVCs. So therefore there was ischemia because there was PVCs. All right, however, there was no inverted T waves. Then in terms of ST segment elevation, as previously mentioned, if ST segment elevation or depression exceeds 0.2 millimeters or 2 small blocks, then it has clinical importance, and we've seen this in lead V2, indicating probably injury to the ST segment or to the anterior part of the heart. However, it was really not as bad. It was that only slightly exceed 0.2 millimeters, and therefore I wouldn't worry. There was no pathological Q waves observed during the test. So it's also good to provide a summary. In terms of summary rate, it was sinus tachycardia. Sinus tachycardia because the person's resting heart rate was 101 beats per minute. Also, you have to identify how heart rate increased or decreased during the test, or whatever happened to heart rate. We've observed a very slight increase in heart rate, and with so heart rate didn't significantly increase with an increase in workload, which is worrisome. Then in terms of rhythm, we saw a lot of PVCs. Most of them was unifocal that originated from one PVC. However, there was one other PVC that looked different from this one we've observed more. Also, there was more than 6 PVCs per minute, which is pathological. There was normal axis, there was no hypertrophy, and there was some ST segment elevation in V2 indicating injury. So yes, that was a summary. Also give your conclusion. So what should happen now? I would refer this patient to the doctor to do more tests on this person before starting exercise. All right, thank you for listening. This is the end.